Nice jacket.
Oh, thanks.
Yeah, and the art, that's fantastic.
Right on. Well, I brought this guy here. I think I bought this in Bali when we were both there many years ago. So
Yeah.
where are you coming to us live now from California, right?
Yeah, San Diego, site of hopefully next year's ASCRS.
All right. Wow. Well, yeah. I guess keep that COVID away and let's get back to the real conferences. That'll be good.
Right.
I remember I was walking past the computer and you were talking about masks. Could you recap that one more time? That was pretty interesting.
Basically, the talk was more about how to open up the office. Again, three things that I had said. Number one was we need to provide a safe atmosphere for the patients, for the staff, for the doctors. We also needed to project that safe environment or safe atmosphere to the patients so they feel comfortable and confident. And then number three is understanding all of this, and while providing this change in the environment, that we still have to provide excellent care. We have to, that's the bottom line, right? We're ophthalmologists and we need to provide that excellent care. Yeah, as far as the guidelines, CMS has guidelines, CDC has guidelines, which are kind of more global. And then the Academy has some really detailed guidelines on how to open, starting from the very beginning, how to schedule an appointment, and then how to meet the patients, what the new waiting room might look like, how to keep the staff safe, and so forth. And part of that discussion was masks. I talked about the N95 mask. They're pretty special. Obviously, they block 95% of small particles, even as small as 0.3 microns. And those really should be reserved for people that are taking care of patients with COVID. The discussion about masks, just in general, I think there's a little bit of confusion about, why we're recommending masks, why we wear masks. So I think in a perfect world, if everybody had an N95 mask, they all got fit, properly for a mask, then that would probably be the best, because there are really two purposes to wear a mask. The major issue is that, especially with the coronavirus, about 20 to 30% of people walking around with coronavirus are asymptomatic. They don't even know that they've got it. Yeah. So how do we prevent those asymptomatic people from spreading the virus? Well, they need to wear a mask. And it doesn't necessarily have to be an N95 mask. They just need to wear a mask so that when they cough or sneeze or, clear their throat, they don't aerosolize and it goes 6 feet away, that it gets caught, the majority of the virus gets caught in the mask. And so you're reducing the amount of aerosolization and the amount of spread of the virus. And then obviously the second part is for people that are caring for patients or at high risk. They're wearing the mask. So essentially, why the recommendation for N90 or for masks in general is my mask is going to protect you, and your mask is going to protect me. So your mask is not protecting you. Your mask is protecting me, and my mask is not really protecting me. It's protecting me. It's protecting you. So that's the reason to wear a mask. It's really the society. It's really for the, kind of the better good for society. So if you refuse to wear a mask, you obviously don't understand that the purpose is, not for your benefit. It's for everybody else, which means that you're being selfish and not trying to protect society in general.
Going to ophthalmology a little bit as well, what are the interesting things that you've been thinking about in terms of the interesting aspects of coronavirus via your lens of ophthalmology, or even vice versa?
As far as, there's a couple of aspects, right? One is theoretical. What's the risk to my staff? What's the risk to me as an ophthalmologist?
Okay.
And then number two is more practical or logistics, right? So how do I take that theoretical risk and then implement something in my practice to be practical, also protective as well. First of all, there is a risk. So, if you look at the studies that have been done, many of them done in China, but if you look at the studies that have been done specifically in ophthalmology, there's about, it's a little bit around, it's about 1% of people with coronavirus did have ocular symptoms. You can't ignore when somebody calls in and they say, I've got some pink eye. Do you think this might be coronavirus? It could be. I mean, it was 1% of the people that were infected with coronavirus. It was in their eyes. Could you culture their eyes? You could culture their eyes. People that had coronavirus in their tears actually had eye symptoms. In coronavirus infected people that did not have eye symptoms did not have positive tear cultures with coronavirus. If you've got a person with coronavirus that has coronavirus and you're doing an eye exam and they don't have any eye symptoms at all, you're going to worry about their breathing, you're going to worry about their coughing, but you don't have to worry generally with their tears. On the other hand, if you do have a person who's got coronavirus and they do have eye symptoms, then you could get it transmitted from the person's tears. And the eye is a mucous membrane, so you could actually transmit from eye to eye. That is possible. The bigger way of transmitting, though, is going to be coughing, sneezing, touching, different things.
Does that have any impact on some of these dry eye devices that we see in ophthalmology?
Yeah, it also, a very simple thing that a lot of ophthalmologists and optometrists do is the very first thing when the patient comes in is there's a non-contact tonometer. It actually blows air. Yeah, so you are potentially blowing air, aerosolizing, the tears in every single, patient. It is it's recommended that ophthalmologists actually wear goggles for all patients. Since we're so close to the patients. We're less than a foot away from these patients. We've also got big plexiglass screens on our slit lamps, so they hang from our oculars, as a coughing thing. We're wearing masks and so forth.
I was checking my LinkedIn feed today and saw that the Ophthalmology Futures event, which happens alongside ASCRS, was going to do at least they're trying to do a hybrid meeting. They're going to have a virtual component, but still try to press ahead with some amount of in-person component, which I'm sure it's probably still a little too early to tell. But I think even that concept in the future, because, we're certainly learning from across the world that, being in the developing world, I'm sure that with ASCRS being a global meeting, there's probably plenty of people and plenty of doctors in Vietnam that would love to attend that meeting and can now in a virtual environment. So maybe in the future, you would at least have a hybrid type of structure where sure, you could come in person. Other people could join from around the world if they wanted to as well.
I think that's a great point. I think the other concept might be the in-person fee, if you will, is one price. Maybe you get 75% of the content that's kind of you've recorded somehow, and then people like Vietnam or other parts of the country or people that physically can't travel, maybe they get 75% of the content for 75% of the fees or something like that.
Right.
Or maybe less, maybe 50% or something. There is some loss in terms of the ability just to kind of either set up a meeting with somebody that you would never, ever, ever run into. And sit down with them, be able to talk to them either from a company standpoint or from expert standpoint, just kind of run into friends and just talk about what are you doing and, how's life and, how are you kind of dealing with this type of medical problem or that type of medical problem and, enjoying, a drink over, a discussion, for example. I mean, there is a little bit more, I think, to the meetings than just the educational content that, the virtual meeting can provide.
And Francis, I remember seeing that I think you were part of a committee now, right? I can't remember off the top of my head, but what's your involvement now with ASCRS?
So I'm the chair of the corneal clinical committee. So there's a bunch of clinical committees: cataract, refractive, glaucoma. There's actually a retina as well. So I happen to be the corneal clinical committee chair. it's been great. I mean, I am very lucky to have rock stars, being part of my committee. So it's very
Yeah.
easy for me. I think the only reason I'm a chair is because I'm the oldest one. So
That's interesting. Yeah. And who would have thought, we would have solved the day to that, because, 20 years ago, we were kind of the younger ones, no?
yeah, right, exactly. Yeah, everybody else was like going to sleep, and we were going out.
Yeah, for sure. The last thing that's just interesting to me, I guess, because we were running a series about corneal transplants and the impact of coronavirus, because it seems like that's also been kind of devastating on that industry. But we've
Yeah.
taken a look at different areas, and I think the one that you mentioned about tears, vis-a-vis these sort of dry eye machines, I guess, if you will. What's going to happen with those? Are those already using disposable pieces, or is there any impact there?
Yeah, so some of them do, have disposable pieces. Many of them do. They are disposable. The BlephX, the True Tear Care, which is the Sight Sciences one, those are all disposable. The LipiFlow, those actuators, those are disposable as well. So those are disposable. The other high risk things are like intravitreal injections. That's a high risk thing. You're obviously right there in there. As far as the corneal transplants, yeah, I mean, you've got to test all these people for coronavirus now to make sure that you're not sending your person in to process corneas, from a high risk, cadaver.
Right.
And the number two is, even though there might not be any ramifications to the actual surgeon, but the surgeon doesn't want to handle, coronavirus. So it does impact, that aspect. And patients probably don't want to know that they've got a coronavirus cornea in their eyes, even though, again, it's not going to impact their long-term outcome. But yeah, I think a lot of the disposable things are going to become a lot more, I think, more appealing, definitely.
Okay. A friend of mine sent a report over the other day that said that hospitals stateside are really suffering right now, financially, but it also noted the different subspecialties in the hospitals, and it looked like ophthalmology had taken the hardest hit. With, like, wow, that's really bad news all around. But I mean, obviously, people are putting their best efforts, putting their best foot forward here at ASCRS. But what is really happening? I mean, is it, what do you think the true impact on ophthalmology is going to be as a subspecialty as a result of this?
Yeah, that's a great question, because I mean, I can tell you, personally, my volume surgically, was down probably, 1% to 5% for a solid, month. Now it's going on 6 weeks, and my clinic patient volume was down to about, I would say, 5 to 10%. Last week, we opened up, and although we were back at, quote, 50%, people didn't want to show up, number one. And then number two was we prioritized people. And so we limited the number of people that we could see. Our schedules are, one patient every half an hour. And then, we had a priority list. And so, again, although we opened up everything and theoretically we were 50%, there was no way I was close to 50%. I was still probably at 25, percent. Yeah. So that's a huge, financial hit personally for me. That's, affecting my technicians. That's affecting my partners. But then, if you think about the patients, the patients are also, we've got record unemployment. They're also, not working. They're also not making money. So when you think about, our patient's going to come in every 3 months for a pressure check or every 4 months for a pressure check. Are they going to purchase their medications, every single time they run out? Are they going to come in anytime they have any type of, irritation or changes in vision? You're probably going to see patients hesitant to come in to see doctors in general for 2 reasons. One is financial, right? They don't want to come in because they don't want to pay the copays. They don't want to buy medications. They want to kind of grin and bear it for a little bit. And the number 2 is they're probably going to be scared, of other people and social distancing, coronavirus, all those other aspects, that they'll kind of deal with it, which kind of goes back to your friend's point about hospitals. There's a lot of people who, had kind of minor issues that became major issues because they didn't come in. And so, so I think, as things kind of move back, we're going to have to gain that trust with the patients that it's a safe environment. I think in general, in the beginning, the fee-for-service stuff, the premium stuff, I think a lot of that, is going to go down a little bit, right? People are going to be a little wary. They it went into the pandemic, maybe on the edge, kind of, not thinking that they're going to need really 3 months or 6 months or, a year of savings. And now people are going to be like, this is a little too fresh in my memory. To put stuff, out there.
So all these years that we've been talking about premium IOLs, premium, well, let's say femtosecond cataract, or all these things, which, yes, they probably did improve outcomes, but in some ways, by a minuscule amount in certain cases. So therefore, what does that mean for the new age of ophthalmology? Maybe, does that mean our segment becomes a bit less premium over time?
Well, I think immediately we're a little less premium. And if you think larger picture, a lot of the dry eye procedures are premium procedures. They're cash procedures.
Okay.
So, patients may say, I'm going to use artificial tears. I'm going to use, the warm compresses, and I'm going to use the baby shampoo. I'm going to use that, that stuff first. And issues, then I might think about some of these more fee-for-service premium, types of procedures. And as far as cataract surgery, you're still going to have the population, the baby boomers that are retired. I mean, their finances didn't really, take that much of a beating. It's kind of the, the working class like us, right? I mean, the people under, 65, under 70 that are working towards retirement. So I think there's going to be a group out there that's still looking for, premium lenses, that's still looking for premium, practice types of offerings. But you're also going to have kind of the younger, I think, people that were kind of heading into that were thinking about that. They may be a little bit more conservative in terms of their financial situations. So, the 50-year-olds, the 40-year-olds, they might not be coming in for LASIK surgery, for example, or the lipoflows, as often.